Okay, welcome to the treatment of substance use disorders and addiction during COVID-19. This is July 17th, 2020. And this webinar is brought to you through the American College of Medical Toxicology and the American Society of Addiction Medicine, jointly as webinar partners. I'm Tim Wiegand, Director of Toxicology at the University of Rochester Medical Center, medical toxicologist and addiction medicine physician, and Gloria Bashevitz, Medical Director of Strong Recovery, Professor of Psychiatry and Department of Psychiatry at the University of Rochester in Rochester, New York, is joining me as moderator. We've got a distinguished group of panelists today. Dr. Carolyn Greer, Addiction Medicine Specialist, the Otis Physician, Medical Director of the Farley Center, Williamsburg, Virginia, Community Assistant Professor, Eastern Virginia Medical School, Norfolk, Virginia, Dr. Nicholas Naka, Emergency Physician and Medical Toxicologist at the University of Rochester Medical Center, Rochester, New York, and Elena Speck, Assistant Professor of Emergency Medicine, Emory University School of Medicine, Atlanta, Georgia. This webinar is presented and available for Category 1 CME under AMA designation and ACCME accreditation. None of our speakers have any conflicts of interest to disclose. And I'm going to begin with the first case. This case involves a 60-year-old gentleman who has senior leadership in an area hospital system, and he calls requesting ambulatory detox for combined alcohol and sedative dependence during COVID-19. He has several previous detoxification and treatment episodes that have required aggressive treatment, including combinations of benzodiazepines and phenobarbital, to get his withdrawal under control in the past. The patient states that he is not able to take time off of work to go to a detox program or inpatient. He enrolled in an outpatient program that had advertised ambulatory detox capabilities. He has numerous previous episodes of treatment, including 3 months prior when he had a brief 2-week hospital stay at an area inpatient unit where he was started on extended release naltrexone after receiving combinations of diazepam and phenobarbital. He reports that he remained sober and he attended meetings and was working with a few sponsors, but then he started drinking in March and hasn't stopped except one night since. His drinking really picked up during the early days of COVID-19. And he cites the stress related to making difficult decisions as the reason for his drinking escalation. At least 5 prior detox episodes in the past 12 months, and occasionally enrolled in an outpatient program, primarily for individual counseling sessions. And he's also had several hospital-based detoxification episodes and presented to the ED and withdrawal and admitted for several days in the past year. So he's really had quite a few treatment episodes, detox, requiring pretty aggressive treatment. His drinking occurs mostly at night as soon as he returns home from work, and then he takes lorazepam during the day, stop the shakes so I can go to work and get through work because he notes tremors, sweat, panic, anxiety. There's not been any seizures, no hallucinations. He says people have noticed and I've lost a job in the past because of it. Patient states he is drinking combinations of vodka and beer. He is vague but settles on either 750 milliliters of vodka or 12 to 15 beers a day, mostly at night. Occasionally he'll have one in the morning before going into work with his lorazepam. He denies taking medications other than the lorazepam and something for my blood pressure. He recently picked up a prescription for 30 tabs of the 2 milligram lorazepam, and you can see this is just a de-identified copy of the prescription monitoring program from the New York State ISTOP.
Hey, Tim, sorry to interrupt. Your slides aren't advancing.
They're advancing on my end. I apologize. I can see the slides as I'm advancing, so right. Maybe someone wants to take over. I'm on slide 11 that I can see. And I can stay on slide 11 right now. These slides will be available to all the attendees, but I'm going to continue with this slide if someone wants to take over from the other end, and then I can read the slide. The patient is adamant he cannot go into detox again, inpatient, ED, or other treatment as his work is critical during COVID-19. I just cannot stop. He mentions phenobarbital outpatient. A few years ago, he was involved in an ambulatory detox that was actually a partial hospitalization and on-site daily assessment, daily meds. His wife held the meds, went home with him at night. He asked if that would be an option during COVID-19. And so my question to the panelists is this gentleman a candidate that you would try to treat outpatient? He's basically refusing to go inpatient or to the detox and plans and otherwise just continuing to work as is, which sounds like it's a disaster. It's not ambulatory detox. There's some other medications that you could initiate for him regarding to his alcohol use disorder. So Dr. Bishevitz, let me start with you. Do you have any thoughts or how would you approach this request?
Well, I think, first of all, basically a lot about this case screams inpatient because he has had 5 recent detox episodes and including hospital-based detox. So there's an increased level of severity. Also, he's had a lot of symptoms, tremor and sweating, though not yet seizures or hallucinations. However, yes, we have COVID-19, and he's asking to go to do ambulatory detox. So maybe you want to try it once and see what happens if you have the ability to do that. But maybe you want to also set up things in advance with him. Say, if this doesn't work, if this ambulatory detox does not work, then I would recommend you go to detox. Would be the next step, that kind of thing.
Yeah, but I agree with the escalation of cares, but he's refusing. He feels, he can't get around being that this is he's a critical piece of his work and can't get away from that. How about Dr. Lee? What are your thoughts if this gentleman approached you? Would you try and put together an ambulatory detox regimen, or would you be doing something else?
Hi, this is Jonathan Lee. Thank you for inviting me. So I would agree that based on the clinical information presented thus far in his treatment history, based on the American Society of Addiction Medicine ASAM criteria, that he certainly would meet criteria for residential/inpatient services, as mentioned by both of you. And I think one of my concerns is that, as you pointed out with this use of prescription lorazepam, is that there's been not just the regular amount of refills over time, but it appears to be an escalating frequency and dosing based on how quickly he's been getting it prescribed and filled, as well as the number of tabs. So I think that the fact that he certainly has severe alcohol use disorder with significant withdrawal symptoms and escalating doses of Ativan is that he would be, I think, better medically management in a residential inpatient setting. And I think the other concern that I have with him is that despite the fact that he feels compelled to stay at work as a hospital administrator, is that he actually is in a safety sensitive position. So with special population criteria based on ASAM is that as far as based on public health and his impact on, in fact, healthcare provider and inpatient care, is that he may require more intensive treatment based on the fact that he could impact other people based on his decision making while he's potentially impaired either while drinking or in acute withdrawal. And I think if we were to go the route of ambulatory detox, which I personally would not, we would really need to look at his psychosocial support, what his home environment is like. I know later in the case we talk about his wife. So I think it's really important to take a look at that as well.
Yeah, those are great comments. And he does not have any direct patient care, but does work with the leadership teams. And from what he had said, they were aware that he was checking into the outpatient and working on some sort of withdrawal management. So, Dr. Greer, do you have any comments regarding this case? What recommendations and how would you approach?
I
I agree with what everyone else has said already. This is a tricky situation when I think we would feel better if he would spend some time in an inpatient or at least a level 3 or above area and stuff, so he could be monitored and his medications could be dispensed appropriately and increase the intensity of care since he's had so many episodes. However, we all have patients who are not willing to participate in the level of care that the ASAM criteria recommends. So I think something different needs to be at least suggested, if whether he takes advantage of it or not, which could include increasing his psychosocial support as far as, well, you're working in the hospital, can you stop by every day so we can, even that face-to-face contact can be helpful. It's a challenge when someone else is prescribing him benzodiazepines and he's seeking treatment somewhere else, especially when the drinking has not stopped. And this is a time where I'm sure we'll get to this, but where I like to try a different agent, which can occasionally be gabapentin.
Yeah, those are good thoughts. And brings me to Dr. Naka. If we could coordinate something, maybe presenting to the ED. Would this be someone that you would try and arrange medications in the ED from, or do you have any other thoughts on the outpatient detox? Any comments?
I think everybody who presents to the ED in a withdrawal state deserves a shot at managing in the acute setting and then discharging to an outpatient plan. This is not. I agree with everything everybody else said, and I think it's an overarching theme that it's pretty clear this patient needs more than an outpatient plan that he's already struggled with in the past. And there's a lot of red flags here: the acute psychosocial stressors, and his mention of a plan that he's trying to formulate already, I think, in his head, I think concerns me a little bit, but I don't think I have a whole lot more to add.
Yeah, you bring up control. I think he had trouble relinquishing control. This is a little bit early, well, not as early in the COVID pandemic and we're also not in downstate where, there were limitations in accessing the detox facilities or the inpatient facilities. We've had a couple of other discussions about ambulatory detox and, acceptance of risk depending on, where you are, and potentially if this were Phoenix, Arizona, or Houston, Texas, if the getting into one of those facilities right now may be very difficult, and trying to do an outpatient protocol may be very reasonable, just because there's no access. Lena, do you have any other comments or suggestions in this before we move on to the next slide? Dr. Steck.
Yeah, nothing earth-shattering. Again, like everyone has said, I agree that he definitely, in an ideal world, needs a higher level of care than outpatient. But I mean, this is something we deal with in our population a lot, either because of COVID or because they have no health insurance and so can't get into any of our facilities. And so then you kind of start crossing into this, pseudo harm reduction realm. Is it better to try something than nothing at all? And so, I think someone had mentioned gabapentin, and I think we can talk about some of the meds later on, but yeah, it's tough. I think he needs inpatient. I would not feel comfortable treating him outpatient, but it may be our only option.
Okay. Dr. Bishevitz, can you go ahead and move the slides and read the case? I'm no longer connected to the internet here right now, at least through the computer, so I can ask the questions, but I just need to have the slides read.
Okay, great. So this patient agrees to 3 days inpatient detox to start treatment and stabilize. He also agrees to stop taking the lorazepam and not continue to pick up the lorazepam from any of the providers that he's been using. And we have a verbal consent for reaching out to these providers. After 3 days, he will continue with telemedicine contact daily for 5 days and on-site check-in on Friday and Monday. He would enter detox over the weekend on Friday afternoon and leave 72 hours later if symptoms are controlled. After this, proceeding with regular contact counseling, XR, naltrexone, and other types of support. So the patient enters into detox. Yes?
No, go ahead. Sorry.
The patient enters into detox, and diazepam is utilized at 10 milligrams PO QID for 3 days, and PRN if CIWA is greater than 10 after the initial dose, with clonidine 0.2 milligrams PO Q4 hours PRN anxiety. He's doing well with symptoms well controlled. He's eating and sleeping. He decides to leave early on Sunday evening after getting an XR naltrexone shot, and that day's 4th dose of diazepam, essentially having completed 48 hours of detox, not the original 72 that he had planned. So he gets 9 doses of 10 milligrams diazepam altogether. On a telemedicine visit to try and talk him out of leaving detox, he appears pretty well. He wants to leave for work the next day, and gabapentin is ordered for QID for 600 milligrams QID for 5 days, and Depakote, valproic acid, is ordered for 500 milligrams BID for 14 days, and then a clonidine patch and also clonidine 0.1 milligrams PRN QID. He picks up these meds on the way home from detox when his wife had driven in to pick him up.
Okay, thank you. So pause here for a few minutes. This was a Herculean effort to try and get him to at least have an on-site assessment and other monitoring rather than to begin anything at home. And basically came down to my saying, I am not prescribing phenobarbital, I'm not prescribing benzodiazepines, and in threatening to go to another provider, and ultimately conceded in this 72-hour plan. And also that he wouldn't be working during the ambulatory detox unless he felt at the end, and it was agreed that he wasn't showing signs of impairment, and he wouldn't be driving during this time frame, but that he would be doing, some whatever he could at home, and following the plan. He also gave verbal consent to reach out to his prescriber for the benzodiazepines and for his wife as well. And I hadn't reached out to them initially because he reported that his wife had taken all of the remaining lorazepam, and he agreed to at least 2 on-site assessments for whoever was available at the outpatient facility, as well as if needed to come in. And if any point his withdrawal was not covered by the protocol, and it should say 900 milligrams of gabapentin QID, not 600. It was a 900 milligram dose QID initially. So he had picked up the meds and was very frustrated. He was leaving 48 hours, but he had picked them up and left with his wife the next day. So any comments or thoughts regarding this initial approach? We'll go back to Dr. Lee. Would you have continued to work with him in terms of prescribing the ambulatory detox meds as he checked out a detox, or anything else you would have arranged?
Dr. Wiggins, thanks for asking me about this. So I think it's a tricky situation. For one, he, in some ways, being a hospital administrator, and certainly in some ways being a VIP, and, not everybody should be treated differently, but I think that in his case, we're doing our best, in your case, doing your best to work with him. So I think continuing care is extremely important, particularly for somebody who, even if they choose to leave earlier, in his case, earlier than what we had planned on. So I think the fact that he's willing to continue to collaborate with the medical provider, at least in some capacity, is key. I think it would be potentially harmful to, not to say abandon, but to say that I'm not going to treat him anymore unless there's another continuing care provider who we know who can manage the ambulatory detox phase. So I think that what you've mentioned is perhaps the best that could have been done at the time. Certainly, assuming his laboratory findings had come back and reasonable for use of valproic acid and his vital signs and whatnot.
Dr. Bashevitz, any comments on the protocol that was used for ambulatory detox? Is that reasonable? Would you have thought of other agents?
No, I would agree with it. It seems like a safe protocol for outpatient detox in a very iffy situation like this.
Dr. Steck, any comments?
No, I agree with what's been said. My only input is that, I've seen and heard of other people using BPA. Personally, I haven't used it a whole lot. I use carbamazepine in addition to gabapentin. Really not because I necessarily think it works better than BPA, but it's just kind of what I've always reached for. So that's just another option for folks, especially if they have pre-existing liver disease and aren't going to tolerate the BPA well.
Yeah, that's a good comment. It's interesting because my perspective, the both of them are listed as adjunctive agents for ambulatory detox. And my feeling is that there's more side effects with the carbamazepine and less for the valproic acid, which basically is explaining increases GABA levels, the inhibition of metabolism of GABA. So the GABA levels are increased. And we use some valproic acid and post-benzodiazepine detox in the hospital setting, or at least I have. Dr. Naka, do you have any comments on use of valproic acid or thoughts about these adjunctive agents for ambulatory detox?
Actually, I don't. I'll just abstain. I think everybody else on the call has a lot more experience with outpatient management than I do. So,
maybe make one comment, Dr. Wiggin. This is Dr. Lee. For use of carbamazepine, which certainly there's good research and evidence to support it as an adjunctive therapy. I think it'll just be important as the medical providers to make sure there aren't any significant drug-drug interactions that carbamazepine may impact as far as induction or increasing levels and whatnot. So there's something that for whoever is prescribing to pay attention to. And certainly if somebody has any issues with, let's say, pancytopenia and other blood dyscrasias, that might be a contraindication as well.
Certainly. And
those are good comments.
Again, that, you have to make sure. I tend to not use it in women, just because of women of childbearing age, just because of the teratogenicity associated with it. So another thing to keep in mind. Someone had asked in the Q&A what doses I've used, and I tend to start at 800 milligrams a day and then taper over about a week.
Very good. Let's move on. Lori, Dr. Bashevitz, can you read the next slide?
So the next morning, he calls his counselor and states he had a few beers and stayed home from work. His wife left to go to their lake house after he started drinking. Provider clarifies that he hasn't started his medications for ambulatory detox at all. And the patient says, I should have started them when I got home. I wasn't thinking. I felt fine then in the morning and I didn't feel good. Then I didn't feel good. So I had a few beers today. So then what do you do now? So in this case, with reassurance, it was decided he could start the meds as long as he's not drinking. And he agrees to the original plan and regimen that we had discussed and was on the previous slide. He stops drinking and starts the meds, and later in the day, he is feeling better. He then takes an Uber to work the next day because he said he felt great and it was working well. The following day, he's driving in, which driving itself is against provider advice during this period, but he's reporting no alcohol use, and he stops in the clinic that evening and provides a urine screen and a check-in. And in the next slide, we see the results of his urine screen. And this is 2 days out of the detox facility. He is anxious, but he calms during the discussion. His heart rate is in the 70s, and he's wearing a clonidine patch. He seems well-groomed, oriented, not confused, no ataxia, and a tremor, though the tremor improves a little bit as he is interviewed. So maybe
you can see the urine screens show, if they're not on this slide, they're on the next, that basically what would be expected, very low levels of ethylglucuronide and ethyl sulfate from the day prior. Gabapentin was measured, and he's taking the gabapentin and diazepam metabolites, as well as lower levels of lorazepam metabolites, which were confirmed, which he had been taking right up to going into the detox. So I don't have any questions. Let's move to the next slide.
Okay, so this is another follow-up on site, and these are results now 1 month in, and he says that he is not drinking and things are going great, and he's attending counseling and group meetings on Zoom. And you could see the results there. Ethylglucuronide is negative, and you can see there's a little bit of oxazepam left, and the urine is negative for nordiazepam and lorazepam, and the gabapentin remains positive at 12,000.
So I was very pleased and had thought that this had gone much better than anticipated, especially since he really wanted to remain in control over components of this. He was following up with his counselor. He really identified with her. He was participating in some Zoom groups and even attending some internet AA groups. And each time I spoke with him, he felt really good. At first, it was every few days a phone call, check-in, just to make sure he's doing okay. Only a couple of on-site visits to provide the urine sample, and things to see. His wife was very pleased. Does anyone have any comments on follow-up from a medical standpoint related to COVID and telemed? How often would you be following with this type of patient? Dr. Greer, do you have any thoughts regarding that?
Well, I would probably, again, continue to check and make sure that the counseling and group participation is continuing on. One of the good things about COVID is that it is easier to follow up with people in a less intrusive manner when using telemedicine versus using, take off time work and come to see me in my office and wait in the waiting room kind of thing. So I would continue touching bases at least a week if you can every single week. I've just found that despite all the clinical interventions, that sometimes being face to face with your medical provider is helpful to identify before a return to drinking starts again.
Those are great points. In this context also, even though it's recommended that we use less on-site drug testing, the confirmation that he's not taking lorazepam, that is ethylglucuronide and ethyl sulfate are negative, and we had used the gabapentin as a marker for, yes, this is his urine. He's taking the gabapentin, which was continued at a lower dose as an anti-craving medication, the 900 milligrams TID, and he was interested in tapering, so it's dropped a little bit to 800 milligrams TID. He had been kept on a lower dose of the valproic acid, which usually I try and taper over a 2 to 4 week period, getting down to pretty low doses. Let's move on to the next slide. Go ahead.
Okay. So the patient calls his counselor on Monday in the morning, 3 months into his treatment. And he says, I started drinking Friday night at a barbecue with friends, and I haven't stopped. Friday, it was vodka, a liter of vodka I picked up on the way home from work. And Saturday and Sunday, it's been 15 beers. This AM, 6 beers until I stopped, and I don't know what to do. I need some Valium or something. The provider then reaches him early in the afternoon as his counselor has been in contact with him. He mentioned several times he was going to get benzodiazepines from a previous provider. His wife was concerned about this, and which she mentioned on a conjoint call with the patient and his wife, though the patient had waived consent to speak directly with her. The patient stopped taking the gabapentin and the valproic acid on Friday night when he started drinking. He had 1 to 2 of the clonidine on Saturday, but nothing else. He hadn't put on a clonidine patch and is asking for a few Ativan or Valium so I can get to work. What about phenobarb? Weren't we going to do that at one point?
So my question is, how rapidly can individuals with alcohol dependence develop the degree of dependence and withdrawal after resumption of drinking? Dr. Naka, do you have any thoughts on that, or want to comment on when people resume relapse with just 1, 2, 3 days after history of alcohol use, a certain degree of dependence? Are they at risk for going back into withdrawal?
Yeah, we routine part of our education to learners on our service is the kindling phenomenon and the propensity for someone to get to a heightened stage of withdrawal after a relapse, sometimes even skipping over some of the initial more mild symptoms and then going straight to delirium tremens requiring ICU level care after a relapse. So definitely there's that concern.
Yeah, great. Thank you. And that's what we had discussed on the phone. Although he had, one of the things that was reassuring is that he had not taken the gabapentin or the valproic acid or any of the clonidine while he had been drinking, and at least over the phone agreed to resume them with a recommendation that he would need to go to the detox or to the ED or an inpatient unit to restart detox if he was having withdrawal symptoms, that it wouldn't be able to be managed outpatient if what we had prescribed, that the doses were re-increased to the previous post-discharge detox doses as well. So Dr. Bishevitz, can you continue?
So the patient is now refusing to go to a detox, to the ED, or to an inpatient facility. Would you order any outpatient medications for withdrawal, or would you instruct him on the meds he stopped taking that weekend? Would you ask him to take them again, and what doses?
And I kind of mentioned already what I had done. I'm just wondering if anyone disagrees with that or would have other thoughts. Dr. Steck, you want to comment? Would you retry, whether it was with your protocol carbamazepine, or at that point tell them it's a no-go inpatient detox or get an ED or the options?
I mean, again, still a very difficult case. You know, on the one hand, you know, you have kind of added to your risk assessment yet another attempt at sobriety that lasted a while but now hasn't gone so well, and you know, someone who really does need still inpatient level of care. But on the other hand, like that prior episode of mostly outpatient detox did work for him for about 3 months. So, again, you know, in the setting of COVID, you know, if this guy's in hospital administration and helping run the disaster response, you know, you try to keep him working. But honestly, I'm leaning towards saying, you know, we're not doing benzos in an outpatient. You absolutely must go to a detox or, you know, the ED or something.
So his wife had been involved in the discussion of the regimen that I wanted him to restart. He was somewhat disorganized on the call, and we made it very clear that this was going to be a make or break attempt here. If his symptoms were progressing despite the protocol, he would need to go to the ED or back to the detox. And Lori, can you continue with the slides? And
Yep. So he was having trouble taking his own pulse, and he was very preoccupied, sort of repeating himself. And I think that's one reason you concluded that you needed to talk to the wife as well. She confirmed, in fact, that he'd only been drinking since last Friday, that she was aware of. And that's always an important phrase there, because people certainly hide their drinking. So he ultimately was given the following plan. And this was discussed with his wife, and she wrote it out for him because he was having such a level of disorganization. Gabapentin, 2 800s at once now, and then 4 times a day. So this was at 2:30 p.m., so 2 at that time, and then 2 more doses that night. Valproic acid, 1,000 milligrams PO right then at 2:30, and then 500 milligrams later that night, and then 500 milligrams twice a day. Clonidine patch is in place, and he will take additional clonidine PO if needed, 0.1 milligrams QID. The provider will follow up in the AM with call. And the counselor did call him later, and he was napping when the counselor called. That evening, the counselor was called, and he is aware that his doctor sent in a prescription of benzodiazepines. There's a back and forth about whether he's actually going to get the prescription from the pharmacy. And the patient is mentioning, well, what if I have withdrawal at work? He's afraid of this. And he then was doing okay after a nap and after the start of medications.
Let's go on to the next slide.
So he picked up a lorazepam prescription from a prior provider. No answers to calls. A voice message was left to follow up with his counselor and to continue the XR naltrexone, but not to take gabapentin, valproic acid, or clonidine while drinking and taking lorazepam. And it was confirmed in the prescription management database that he had indeed picked up this lorazepam. So, thoughts or questions at this point?
So at this point, working with this gentleman, the control again has become an issue, and I'm concerned with the mix of prescriptions, and had left a message instructing him not to take them and to follow up with his counselor, and that my recommendation was that he needed a higher level of care and that he should not be at working. We could discuss whether or not one should call his work or what the reporting is. Again, he's not directly taking care of patients, and wrestled with that, but did not make any calls. I knew that he, through his wife and what he had mentioned, that his coworkers were aware of his drinking problem. For about 24 hours, he didn't answer calls. And then when he realized that he wasn't going to have ongoing instruction support over the gabapentin and the valproic acid, he did agree to go into a hospital-based detox program. And that was literally what I was notified just recently, and is in a hospital-based detox program with the recommendations for a prolonged inpatient after this, not resumption of work activities. I believe something happened at work. He had found a trazodone prescription and was taking that in the afternoon to knock himself out at night, and then planning to try and take lorazepam throughout the day. And I think they just had an intervention, and his wife confronted him, and he went to a hospital-based program. So the interest of time, let's move on to the next case, and Dr. Lee can present that case. It's regarding a different type of patient.
Yes, thank you, Dr. Wiggin. So this is a case of a 35-year-old physician who was referred by his employer for a residential evaluation due to signs of impairment while at work. It's in the hospital system. He reports increased stress with taking care of patients diagnosed with COVID-19. During the evaluation process, he admits to daily use of Kratom and requests medication management of acute withdrawal. After stabilization, he is interested in taking a medication to prevent relapse on Kratom. The questions are, what are the considerations for treatment regimen? And what are the considerations for drug testing and or monitoring? And for Dr. Wiggin, if you or the panelists have any questions about the case, I can provide more details.
I guess I have a question besides the Kratom. What is his use history? Was he drinking anything, any other substance in the past? Or is it really just that he picked up Kratom kind of out of the blue? That would be very atypical in my experience working with some patients who we've had that have used Kratom. Usually they're coming to it from opioids. Occasionally, initially, prescription opiates, chronic pain, they're looking for an alternative. In this case, it's all over. There's 2 Kratom shops in Rochester, New York, and it may have been somebody just recommended, hey, try this, chill out. It'll help you at the end of a busy shift. So what's his history?
Oh, yes, absolutely. So in his case, just to provide the background on the substance use history, is that he did use opioids, first use at age 16. And he noticed that he really enjoyed the sensation of the prescription pharmaceutical opioids at that time. And during college, as he was using, I would say misusing and abusing opioids in different ways, he also used heroin for a period of time and decided at some point, and it wasn't through formal treatment for opiate use disorder, but at some point he stopped using after he got married. And it was, according to him, in the last 3 years, and he happens to be anesthesia resident in training, he said that he didn't think that people would test for Kratom. So over the last 3 years, he had started to use Kratom in order to get the same feelings that he experienced with the opioids. And he felt that it was a way for him to manage his anxiety, particularly restlessness, things. Some of the symptoms were from opiate withdrawal in the past, but for him, he thought that it was helping him with his energy, his mood. He does have a co-occurring anxiety and depressive disorder that's been treated previously too. And according to him, is that during the onset, particularly this year, moving into really February, March with the COVID-19 pandemic hitting the US and really the entire world, is that he had a lot of fears and anxiety related to going to work, particularly with whether or not he was being provided and utilizing the PPEs properly to protect himself. He had concerns about just procedures because part of his job was to intubate patients. And then the other level of change for his workplace is that due to utilization of staff and also to decrease exposures, his anesthesia team was divided into two, effectively a team A and a team B. And he found himself working more days and nights in a row when he was on for a week, and having, quote, more downtime when he was off for a week, with the opportunity and accessibility as he thought of using more substances, including Kratom during that time. According to him, prior to coming in for the evaluation, he also did start to pick up opioids such as, in his case, he said it was a oxycodone pill that was provided by a friend of his. And your question about alcohol use, he does have a history of binge drinking, but not on a regular basis prior to the evaluation. And it's also interesting with him is that he has an interest in taking either energy drinks, had used his spouse's prescribed stimulants such as Adderall in the past. And in his case, he actually thought that the Kratom was helpful to, sounds like, mimic the feelings that he was trying to achieve with either opioids or stimulants.
And one quick other question is, what was the symptoms of impairment that was noticed? Was he in withdrawal or did he have intoxication? Do you feel that was what brought it to people's attention?
Sure. So at the workplace, there were coworkers that mentioned that he was stumbling, and they noticed that sometimes that his were dilated. He appeared to be more talkative, more gregarious than his prior self. He was actually having some issues with performing procedures that he was proficient at, such as putting in IVs, which in the past would not be an issue, but he had to redo and had issues with what looked like fumbling around. On the night shifts, they also observed that he would be, quote, missing or disappear for 30 minutes or more at a time when they were looking for him. So those were some of the concerning behaviors.
Dr. Greer, have you worked with any of patients that have been using Kratom, become dependent, and sought treatment?
A little bit, mostly anecdotally, not necessarily brought because of sense of impairment, but rather maybe some younger adolescent patients just saying, hey, what do you think about this? Or I was able to get this. It's not as prevalent in the Midwest as it is, I think, on the coasts. And I know we'll talk a little bit about this down the road, but we've tried a little bit, not that there's a lot of literature to support this, but like Dr. Lee said, a lot of times there's a history of opioid use that precedes kratom use. We've tried using buprenorphine to treat not only the withdrawal, but maybe to help with ongoing use, and have had some success.
Dr. Mashevitz, have you seen a lot of patients for kratom dependence?
That's very rare because we're more of what you might think of as a tertiary outpatient place where we have a lot of methadone maintenance and also buprenorphine treatment. Kratom is more expensive than heroin and fentanyl and other things. So that's often a barrier. Once you're using a great amount of opioids, you usually progress to whatever is cheaper.
Dr. Naka, can you comment on some of the issues we've had in the hospital with some kratom users?
Sure. So we've run into some cholestatic hepatitis issues. We've run into certainly dependence issues. We have successfully started Suboxone and referred for outpatient treatment. And the other issues that we've run into have been related to adulteration with kratom, where we identified a phenylethylamine in a supplement that was sold as kratom, and a patient had a hemorrhagic stroke secondary to that adulteration. So not something new as far as herbal supplement marketing, but certainly problematic.
And there's a couple of chat questions. How was he using the kratom extract powder capsules tea? What was the dose? Which is interesting. In recently reviewing a paper summarizing some kratom cases, the dose question came up, and the dose is always, without the regulation, the dose is very difficult to determine because some of the preparations are extracts, some of them are infusions, some of them have had synthetic methadone added to them. If they're oxidized or exposed to the sun for a prolonged period, they're more active metabolite. So the dose kind of becomes somewhat of a moot point, in my opinion. But Dr. Lee, do you know how he was using? What was the dose per se?
Yes, sir, Dr. Wiggins. So he reported that more recently, as he was experiencing more stress, again, this is in his self-report, 4 tablespoons a day, 4 times per day. So that was the way that he was effectively dosing it. And it was effectively QID, at least. And he would either mix it with the fluid and then drink it, or just take the extract. I think it is a good point that in this case, he didn't provide the actual number of grams, but then based on either him, but also other patients that I've taken care of, is that when people are either buying or ordering these substances, such as kratom, is that they sometimes will look for what strain the kratom is coming from, whether that be the green or white vein or red veins. And what, at least according to the people who sell it and the users, is that the white vein strains are said to create a more of a stimulant euphoric high, versus the red vein kratom, which may provide more of an opioid/sedative symptom relief. So as far as the symptoms that, whatever desired effect they're looking for. And in his case, there wasn't details on that.
Okay, continue with the slides.
Sure. So then I'm going to move forward with the next slide, which talks about kratom composition. And based on studies, the leaf analysis, which again, this is coming from the botanical product, which is Metraginous speciosa. So there's at least 40 structurally related alkaloids, flavonoids, terpenoids, saponins, polyphenols and various glycosides that are found in the botanical leaf. Greater than 25 indole alkaloids with reported anti-nociceptive, anti-inflammatory, antidepressant, and muscle relaxant properties. Of note, with this breakdown is that the two presumed psychoactive substances is metragenine, which makes up about 66%, and 7-hydroxymetragenine. I'm just going to move to the next slide unless there's any questions about this one.
No, you can move on.
So with the kratom active constituents, the metragenine undergoes chemical oxidation, biotransformation to convert into 7-hydroxymetragenine. Both active psychoactive constituents are opioid agonists. So in vivo, there are signs of tolerance, cross-tolerance to morphine, which is seen on the right-hand side of the slide. And precipitated withdrawal has been observed when naloxone is administered. In fact, naloxone has been administered for what has been thought to be either co-occurring drug overdose with kratom as well. And I think one thing that I would like to point out with the mechanism of action is that as far as the stimulant effects noted that I mentioned earlier, typically at lower doses ranging from 1 to 5 grams, the opiate effects are often observed at higher doses of greater than 5 grams. And it's interesting that the metragenine has a relatively short half-life, which correlates to users dosing every 4 to 6 hours. And oftentimes for patients who are dependent on kratom over time is that they're dosing frequently, and often they're in the 14 to 42 gram range if they actually know how much they're taking per day. And it's also important to note that with the mechanism of action is that the metragenine, 7-hydroxymetragenine, they tend to have more of a mu opioid receptor agonism, a weak antagonism at the delta and kappa receptors. Through other mechanisms, it's thought that there's a serotonergic antagonism at the 5-HT2A receptors, as well as noradrenergic agonism at the postsynaptic alpha-2 receptor pathways. I'm going to move to the next slide, unless any questions about the mechanism of action.
I just want to comment. We can certainly take additional chat questions. I know that colleagues have asked me about kratom more and more frequently lately. So the audience chats or panelists, if you have other experience with kratom, please comment. Elena, is this a frequent?
Go ahead, Dr. Wiggins.
Elena, is this something you're seeing in Georgia? Is kratom legal or banned?
To be honest, I don't know our state's statute on it. I think as one of the other panelists mentioned, we tend to see it more as kind of an incidental substance of use where people, are either trying to use it to mitigate withdrawal or it's, quote, natural alternative to opioids. We have had a couple people come through and one of whom has been successful now for several years in our clinic who have used large doses of kratom and have been really successfully managed with buprenorphine. What I think is really interesting in this gentleman's case is that he's a physician. And so I think with many of the physician assistance programs, MAT or MOUD with buprenorphine products is not permitted. And so, an alternative for him might be, extended release naltrexone, plus or minus some clonidine, plus or minus an SSRI for his underlying anxiety and depression. But even though we've had, a couple good cases who've been really well maintained with bupe, I don't know that that's a good option for this guy just because of his profession.
So,
you bring up some interesting case comments, and no, I'll address them after you. Go ahead, Dr. Lee.
No problem. I think that those are very good points. As far as with this co-occurring anxiety, depressive disorder. He actually was prescribed antidepressants in the past, and more recently has been taking venlafaxine, which that's been part of his pharmacotherapy. And I think one of the things that's hard, I think, because of the emerging substances of abuse or of addiction, is that Kratom users in the U.S., the rough estimate is that there's about 3 to 5 million based on surveys, also based on membership information provided by the American Kratom Association. And I think the other concern is that the Monitoring the Future survey does not ask any questions about Kratom use in our secondary school students, adolescents. So from a prevention standpoint, I think that we're not taking a good look at that data so that we can actually follow it as the, from a preventive standpoint from children all the way up to adults. So those are some things. And then as far as the fact that he was asking for treatment, and I do agree that for his acute withdrawal, we were looking at it based on the literature reviews and also just other case reports, is that oftentimes Kratom withdrawal does have many similarities to acute opiate withdrawal. And it tends to happen at the onset between 12 to 24 hours from his last use. And typically it doesn't usually last much more than 4 days, but that's variable, of course. And the physical withdrawal symptoms include mydriasis, rhinorrhea, lacrimation, nausea, vomiting, diarrhea, sweating, fever, chills, myalgia, muscle spasms. And some of the psychological symptoms might include mood swings, anger, depression, nervousness, restlessness, insomnia. And not in his case, but there's been case reports of people who either maybe due to sleep deprivation or other mechanisms start to have hallucinations. So as far as the treatment of Kratom withdrawal, based on the literature review, is that management of the hyperadrenergic state with supportive medications such as clonidine, gabapentin, NSAIDs such as ketorolac for very short periods of time to avoid any GI or bleeding issues. And then going on to using medications such as buprenorphine formulations. There's also reports of using methadone for the management of the acute Kratom withdrawal symptoms. So, and then as far as the, I guess we'll get to the part about what to do after the acute withdrawal symptoms, because there's some slides related to that as well. Any other comments, Dr. Wiggin, before we talk about drug screening?
No, you can go ahead.
Okay. So then with Kratom drug screening is typically not part of our standard routine urine drug screen. So, and I think that with him being a physician and also more scientifically, as far as educated, is that was perhaps part of the reason that he was using it, is that he knew that for the most part, people don't screen for it. So special confirmatory testing can be done in different ways, such as with gas chromatography coupled with mass spec, liquid chromatography with linear ion trap mass spec, and electrospray tandem mass spec. It can be detected in urine samples for about 5 to 6 days. And then there's been a case report in a chronic user who was still remained positive at 14 days after last use. And to tie his drug screen to this case or to the laboratory testing is that his metragenine, which initially what the lab that we used did was there was a screening test based on immunoassay. And based on a positive immunoassay at a testing threshold of 5 nanograms per mil, all presumptive positives are then confirmed by definitive liquid chromatography tandem mass spectroscopy at a threshold of 1 nanogram per mil. So his number came back at 102. So 102 nanograms per mil was his confirmed test. And that was specific for the metragenine. Any questions about drug testing?
It's just a comment. It is available through multiple different laboratories. Usually, it's an add-on to panel, he used it in a couple of cases where individuals have identified that they were using Kratom. Just a reminder that it's not going to show up as a standard opiate or on an expanded panel unless you're specifically looking for the metadronine metabolite assay, and would be available as an add-on through like a physician health program, in somebody that's identified as using Kratom. There was one comment in the chat that says some of my bupe patients working in treatment seemingly successfully would use Kratom for the high and weekends, as it did not interfere, and then it was not a problem for probation. I have to comment, I've seen Kratom use in individuals that are in monitored programs that are on probation outside of physicians or professionals. We only maybe 1 or 2 more minutes, and so we can end with this case. The third case will move to August, and I'll be able to have a guest expert as well participate, which will make that, I think, more worthwhile. An obstetrician was involved in the care. Are there any other comments regarding the Kratom case, Dr. Lee?
Yeah, sorry to take so long. So I think the very last thing would be for medications to prevent relapse. So aside from case reports and also, as you mentioned, anecdotal experiences using buprenorphine, methadone, there actually are a number of case reports of using naltrexone, particularly the extended release naltrexone, with good outcomes. So I would agree with the other panelists that in his case, that's what he's agreed to, is to get on the extended release naltrexone. Thank you.
And I've had success, usually initially at lower doses of buprenorphine, but most of the patients don't stabilize until they're at higher doses. The initial withdrawal is effectively treated, but they have craving, and a combination of not just buprenorphine, but early sympatholytics and then an SSRI or an SNRI seem to be helping most, because it's not just simply the opioid withdrawal. There's, as you mentioned in the pharmacology components, there's other pieces. I think that probably Kratom withdrawal mimics both opioid withdrawal as well as SNRI discontinuation syndrome. So your venlafaxine was an excellent choice, with the clonidine. They otherwise just don't quite feel right. And there's some literature that was included, case report, Journal Addiction Medicine, giving an overview of a couple of cases. So we won't cover case 3, and I'm just going to read. I had a poem at the end of the last presentation. I'm going to end with another Raymond Carver poem that I have up, and I can just go ahead and read this. And it in particular pertains to the first case, and it's entitled Wine. And it goes, reading the life of Alexander the Great, Alexander, whose rough father Philip hired Aristotle to tutor the young scion and warrior, to put some polish on his smooth shoulders. Alexander, who later in the campaign trail into Persia carried a copy of the Iliad in a velvet-lined box. He loved that book so much. He loved to fight and drink too. I came to that place in the life where Alexander, after a long night of carousing, wine drunk, the worst kind of drunk, hangovers you don't forget, threw the first brand to start a fire that burned Persepolis, the capital of the Persian Empire. Ancient even and Alexander's day, razed it right to the ground. Later, of course, next morning, maybe even while the fire roared, he was remorseful, but nothing like the remorse he felt the next evening when, during the disagreement that turned ugly, and on Alexander's part overbearing, his face flushed from too many bowls of uncut wine, Alexander rose drunkenly to his feet, grabbed a spear, and drove it through the best of his friend Cletus, who'd saved his life at Granicus. For 3 days, Alexander mourned, wept, refused food, refused to see to his bodily needs, even promised to give up wine forever. I've heard such promises and the lamentations that go with them. Needless to say, for the life of the army came to a full stop as Alexander gave himself over to his grief. But at the end of those 3 days, for fearsome heat beginning to take its toll on the body of his dead friend, Alexander was persuaded to take action, pulling himself together and leaving his tent. He took out his copy of Homer, untied it, began to turn the pages. Finally, he gave orders that funeral rites described for Patroclus be followed to the letter. He wanted Cletus to have the biggest possible send-off. And when the pyre was burning and the bowls of wine were passed his way during the ceremony, of course, what do you think? Alexander drank his fill and passed out. He had to be carried to his tent. He had to be lifted, to be put into his bed. And thank you all for attending. Thank you, panelists, for joining this Friday. Please, next month in August, we will start with the second case and have some guest expertise joining as well. And a reminder to complete your evaluations, and CME credit is available for advanced providers and physicians in completion. And both ACMT and ASAM will have the live recording streamed on their websites if you want to have access to the slides and the recording. Again, thank you and have a great weekend.